بسم الله الرحمن الرحيم. محاضرة النهاردة عن الشوك هنتكلم عن definition, classification, and for each type of shock, pathogenesis, pathophysiology, clinical picture, and treatment. Shock is a state of peripheral circulatory failure characterized by hypotension, impaired tissue perfusion, and disturbed cellular metabolism. Shock is classified into hypovolemic, septic, cardiogenic, obstructive, endocrinal, neurogenic, and anaphylactic. Hypovolemic due to diminished blood volume. Septic due to complex interactions caused by sepsis. Cardiogenic due to insufficient myocardial function. Obstructive due to interference with cardiac filling. Endocrinal due to acute deficiency of corticosteroids. Neurogenic due to pooling of blood in peripheral circulation. Anaphylactic due to antigen-antibody reaction. The first type and a common type of shock is the hypovolemic shock. Hypovolemic shock occurs due to blood loss, plasma loss, or fluid loss. And regarding the pathophysiology, there is cardiovascular response, there is cellular metabolism, and the body organs affection. The cardiovascular response occurs at two levels, macro circulation and micro circulation. Macro circulation, there is nervous response and hormonal response. Blood loss will cause decreased arterial blood pressure, altered blood gases, and both will stimulate baroreceptors and chemoreceptors. And this stimulation will cause cardiac stimulation, systemic vasoconstriction, flow and volume redistribution. Also, blood loss will activate renin, angiotensin, aldosterone system, and it will cause catecholamine release, vasopressin release, and all will cause vasoconstriction, increased volume, and cardiac stimulation. At the level of microcirculation, there are two phases, compensated phase and decompensated phase. Compensated phase occurs with loss of less than or around 15% of blood volume. Hypotension will cause reflex, contraction of pre-capillary sphincter with decreased blood flow, capillary hydrostatic pressure, and this will cause fluid shift by plasma proteins from tissues to blood. And if blood volume is regained, this is reversed. But if shock is prolonged, next phase will occur. The next phase is the decompensated phase, which occurs with a prolonged shock or loss of more than 15% of blood volume. The decreased tissue perfusion will cause accumulation of carbon dioxide, acid metabolites, relaxation of pre-capillary arterioles, but not the post-capillary venules. This leads to congestion of capillary bed and translation of plasma through the capillary wall, and this causes progressive depletion of blood volume. If this is prolonged with impaired tissue perfusion and cellular anoxia, a vicious circle occurs, and this will end in cellular death, which is called death cycle of McDowell. Regarding cellular metabolism, the source of energy, tissue anoxia will change the cellular metabolism from aerobic to anaerobic. This will cause lactic acid accumulation and metabolic acidosis. Carbohydrates, there will be increased glycogenolysis. Fats will be increased lipolysis. Protein, there will be increased protein breakdown. The affection of shock on the body organs in the heart. Initially, there is increase in the heart rate and contractility to increase the cardiac output, but later contractility is impaired due to decreased myocardial perfusion and by the effect of myocardial depressant released in shock. For the kidneys, in shock, blood is diverted from the kidneys, causing renal ischemia, polyuria, and if this is prolonged, the ischemia will lead to renal damage and eventually renal failure. In the lungs, initially, there is tachypnea to increase oxygen carrying capacity of blood, but later there will be injury of the alveolar capillary membrane, which may cause ARDS acute respiratory distress syndrome, adult respiratory distress syndrome, and this may eventually lead to pulmonary failure. The intestine shock will cause vasoconstriction of splanchnic vessels to divert the blood to important organs, but prolonged shock will cause ischemia, gut barrier dysfunction, translocation of bacteria, and endotoxins from its lumen into the circulation. The clinical presentation of hypovolemic shock, this will include the signs and monitoring of shock. The patient is initially conscious, then semi-conscious, and if coma occurs, this is a serious sign. The pulse is rapid and weak. There is hypotension, temperature is subnormal. There is rapid and shallow respiration. The skin is cold, pale, and lightly cyanosed, and collapsed peripheral vein indicates severe hypovolemia. The shock is monitored by vital signs, central venous pressure, urine output, hematocrit, arterial blood gases, arterial blood pH. And according to the blood volume deficit, shock has 3 degrees, moderate, severe, and profound. The prophylaxis of hypovolemic shock in traumatic shock in injured patient, shock is prevented or minimized by proper first aid measures and by transferring the patient rapidly to the hospital for definitive treatment. For operative shock, this is avoided by good preoperative measures like avoiding starvation, purgation, and good operative technique, ensuring adequate anesthesia, and very good post-operative management, including keeping the patient in the recovery room till he is fully conscious, and after that, giving sufficient amount of IV fluids and so on. The treatment of hypovolemic shock include first aid treatment, fluid replacement, and adjuvant treatment. The first aid include A, B, C, D, E. The injured part should be initially dressed, elevated, and suspended. Putting the patient in the shock position. The body heat is kept by keeping the patient warm and giving sedatives and analgesics. Fluid replacement is made by blood colloids like plasma, dextran, and so, and crystalloids. The adjuvant treatment is according to the situation and the case by vasopressors, vasodilators, diuretics, sodium bicarbonate, steroids, cardiotonics, and antibiotics. The second type of shock is the septic shock. This is a serious type of shock and difficult to treat. It is due to serious infection by gram-negative and less commonly by gram-positive organisms. The pathogenesis of septic shock, there are predisposing factors and source of infection. The predisposing factors are all problems that suppress the body immunity, like old age, diabetes, liver cirrhosis, neoplasms, hypovolemia, indiscriminate use of antibiotics, chemotherapy, corticosteroids, and so on. And the source of infection could be strangulated bowel, peritonitis, leaking anastomosis, cholangitis, pyelonephritis, neglected venous catheter used for long time. And in septic shock, there is endotoxin blood interaction and bacteria tissue interaction. The endotoxin blood interaction, endotoxin released from the dead gram-negative bacteria becomes activated by combination with an antibody and a complement. This activated endotoxin will release vasoactive substances like histamine, serotonin, kinine, in addition to catecholamines. All these will cause intense visceral-peritoneous vasoconstriction, causing stagnant anoxia. The bacteria tissue interaction, this interaction of living bacteria and with the damaged tissue will cause arteriovenous shunting. In septic shock, there is 2 phases, hyperdynamic phase and hypodynamic phase. In hyperdynamic phase, this occurs early with living bacteria, and this is reversible. Clinically, there is fever, chills, increased heart rate, hypotension, warm and dry skin. In hypodynamic phase, this occurs late with the endotoxin in blood, and in this situation, it simulates the hypovolemic shock. The treatment of septic shock, prophylactic and therapeutic. Prophylactic by avoiding the predisposing factor, and therapeutic by restoration of normal hemodynamics and control of infection and other measures as required. For the cardiogenic shock, the pathogenesis is acute myocardial infarction following cardiac operation and improper management of other types of shock, cardiotoxic drugs, and so all this will affect the myocardial contractility. The cardiovascular response, initially, the hypotension will cause sympathoadrenal response. This will increase blood pressure, and also there will be increased peripheral resistance. All this will cause a greater workload on the damaged myocardium, and this will cause further damage to it, leading to cardiac failure. The biochemical changes are as in hypovolemic shock. Clinically, the characteristic features are congested neck veins and increased CPP, other findings as in hypovolemic shock. Treatment, general lines as in hypovolemic shock. The specific treatment is oxygen therapy, cardiotonics, and treatment of underlying pathology like myocardial infarction. In obstructive shock, there is decreased filling of the right side of the heart in tension pneumothorax, cardiac tamponade, massive pulmonary embolism, and the characteristic findings are decreased cardiac output, increased jugular and central venous pressure. Treatment is that of the specific cause. Endocrinal shock, this could occur in patients with Addison's disease and in patients receiving continuous steroid therapy when they are exposed or subjected to stressful situation like infection or surgery. The pathology and presentation, the shock is due to failure of release of corticosteroids from the suppressed adrenal cortex to cope with the stress. The patient is in a severe shock with hyponatremia and hyperkalemia. Treatment is prophylactic. The patient liable to this problem should receive additional dose of hydrocortisone IV at a stressful situation, and in established causes, a large dose of hydrocortisone intravenous and crystalloid infusion beside treatment of predisposing factor. In neurogenic shock, there is extensive vasodilatation, peripheral pooling of blood, which leads to sudden decrease of venous return and the blood supply to brain vital signs. This occurs in vasovagal attack and spinal shock. Clinically, in vasovagal attack, the patient collapses and falls to the ground. Pulse is normal or there is bradycardia and weak pulse. Blood pressure, hypotension. Temperature is normal or subnormal. Skin is warm. Respiration is slow and shallow. And the treatment is as in hypovolemic shock, but the characteristic treatment for this case is the vasopressors, which is adrenaline may be required to control this condition. Anaphylactic shock, this is an antigen-antibody reaction which occurs following administration of drugs, serum, dextrans, or whatever. This will cause a release of large amount of hypersensitivity mediators like histamine, cytokines, and leukotrienes. The released mediators will cause widespread vasodilatation and sudden hypotension. Treatment is by putting the patient in shock position, IV fluids. The characteristic treatment is IV corticosteroids and IM vasopressors and antihistamines. So shock could be hypovolemic, septic, cardiogenic, obstructive, endocrinal, neurogenic, or anaphylactic.